This is now the case of a patient with a single lead ICD, hospitalized for syncope. You could find this episode labeled SVT in the memory of the device. On the tracing, you can recognize two different signals, one of low amplitude, quite fast, and one of higher amplitude, slow, at a rate of around 35 beats per minute. So in this patient, there was oversensing of atrial tachycardia on the ventricular channel, with a slow ventricular escape rhythm, since this patient had a permanent atrioventricular block. The patient did not receive inappropriate therapy because of his diagnosis of SVT based on the irregularity of the cycles, the device coupling for measuring the irregularity both the atrial signals and the ventricular signals. It is very likely that since the escape rhythm was intermittent, the syncope was related to a long pause and to a bradycardia. Atrial oversensing by the ventricular lead traditionally occurs in two clinical situations. First, an RV lead dislodgement to the atrioventricular junction, and second, when an integrated bipolar lead has been positioned near the tricuspid annulus, the RV distal coil crossing the valve. This observation is more frequent in patients with small Rs or small RV cavities, like children or patients with hypertrophic cardiomyopathy. Atrial oversensing may also be observed in other infrequent situations: an RV lead unintentionally implanted in the coronary sinus, an RV lead insulation defect in the atrium allowing for sensing of atrial activity, or an atrial lead to RV lead interaction, the atrial lead contacting the RV lead during atrial systole and generating a signal sensed by the RV lead. Atrial oversensing by the ventricular lead can be revealed by two different situations. The first one is, like in this example, the occurrence of ventricular pause, because the ventricular pacing is inhibited by the oversensing of atrial signals. It can be atrial tachycardia, like in this example, or the sinus activity in a dependent patient with complete atrioventricular block. This is now a second patient with the problem of P-wave oversensing, but this time during sinus rhythm. You can see that the right ventricular channel both senses the R-wave complex and a small signal corresponding to the P-wave. So this is the second kind of problem that you can encounter in patients with P-wave oversensing. After a prolonged oversensing, there was a diagnosis of VF, and this patient received an inappropriate shock. This tracing will also be described in the chapter dedicated to the functioning of the secure sense algorithm. You can see once more that there is P-wave oversensing, but this P-wave oversensing is restricted to the bipolar channel and is not observed on the discrimination channel. Therefore, there is a discordance, and the device will diagnose a problem of oversensing, and the therapies will be inhibited. So, in a certain number of patients, the secure sense algorithm may also decrease the rate of inappropriate therapies in the case of P-wave oversensing.